Welcome to Share the Health, a new podcast from the Ross County Health District, where we discuss health issues that affect our community. I'm your host, Sarah Smith. Today I'm joined by Dr. Christopher Brown, the Medical Director of the Ross County Health District. So welcome, Dr. Brown.
Thank you. Thank you for inviting me. I really feel honored about this, and it's always good to share information about public health. And those are my two passions. So thank you for this.
So you've got a lot of letters behind your name. So can you tell us about what some of those mean?
So a lot of people may see this when you see, doctors, nurses, different health professionals. You'll see their names, and then you'll see these letters that are behind there. And, and I happen to have, I have a few of those. So for me, I have an MD behind my name. I have an MPH, and those are my degrees. And then I have these FACP, FASN, and these also are behind my names. So we'll kind of start with the ones that I think most people are familiar with. So the first names the letters that are behind my name are the letters MD, and I think most people recognize that. So that's medical doctor, and so what that designates is that an individual has a training program and graduated, and that allows them to have this medical doctorate degree. Now there's also DOs, and they're very very similar. There's a little more manipulation goes on with the DOs, but MD stands for medical director, medical doctor, mm-hmm. And so that means that you have graduated from a medical school. The other letters, the next letters are going to be MPH, and what an MPH is a master's in public health, and what a master's in public health is. Public health is, of course, with the health department, we think more about populations. So doctors will think, or physicians will think more about an individual. So my duty, we actually take an oath as part of our graduation, where where the individual is our focus. We really focus on that individual. And then there's public health, where you mm-hmm. look more at a population. And you look at that and try to take care of a population of people. So I happen to have one of each one of those degrees. My master's in public health is actually in healthcare and prevention. Mm-hmm. And so, kind of work looking at healthcare and trying to prevent diseases from happening is what that's from. Now, I also have some other letters. One is FACP. It's a fellow of the American College of Physicians. And so what happens is that, once we graduate, if we're working in a specialty, so I work in internal medicine, the doctors for adults, and they actually, if you do extra work, so of course, if I just go and see patients, that's honorable work and that's what you do. But if you happen to do things like teaching, research, maybe you write articles and things of nature, there's a certain criteria they have where they will bestow upon you what they call a fellow. Of whether it's the American College of Physicians, which is internal medicine. I also have an FASN, which is a fellow of the American Society of Nephrology. Mm-hmm. And so if you do certain things, you will actually get those designations, and you can put those letters behind your name as well. Now, granted, it gets a little long, but that's basically what it means. For most people, like I said, the MD, the degrees are what you really want to focus on, so the MDs and MPHs. Mm-hmm. But like if you want to do research, if you are talking to, giving talks, those extra letters just kind of denote that you've had a history of doing, I call it extra work, is basically what it is.
Mm-hmm. Well, it sounds like you have definitely done the necessary training to be knowledgeable in all these topics that we'll be going over today. So can you briefly describe your professional background, like where you got started?
Okay. So my professional background, I'm actually from North Carolina. And I actually went to medical school at the University of North Carolina, Chapel Hill. Actually went to undergrad at North Carolina A&T State University. And then went to the University of North Carolina, Chapel Hill, which is quite interesting because at the time I was entering, UNC changed from the, they actually got the "the" out, and then I went to a school where the "the" was emphasized. So I went from University of North Carolina at Chapel Hill, where I did my medical school, as well as I did my master's in public health training, and then went to the Ohio State University. Oh, wow. And that's where we did do your training. So for physicians, you do your school, what I call it schooling, mm-hmm. which is medical school. You get your MD or DO, and then you go to training. you have to go train before you can, start seeing people.
Mm-hmm.
And this is called a residency program. And so the residency program is for medicine, and most primary care specialties is going to be about 3 years. And so I did that at the Ohio State University Medical Center, and that was 3 years. And then after that, decided to focus on nephrology. So and we do what we call a fellowship. So that's an additional 2 years.
Mm-hmm.
And I did that at the same place. And after that, I actually stayed on for faculty for a few years at Ohio State. And after that, decided to go out into the what I call the private world and practice there. So that's a kind of a brief overview of the base of my professional background, or at least the training part of it. After that, did a lot of community-based work. Also did work in I've worked in North Carolina, worked in a lot of places in Ohio. Not only Columbus, but also like a lot of rural areas around here as well.
Great. So what drew you to pursue a specialty in kidney health?
Kidneys. Love the kidneys. So what? Love the kidneys. So what drove me to, or what attracted me to kidney health, is that I felt like the kidneys are, they're almost a stepchild organ. Everybody knows about the brain and strokes. Everybody knows about heart attacks. The heart.
Mm-hmm.
But like I feel like the kidneys are a unique organ they're very important to the body. A lot of people don't know how important they are, and you don't really think about them until they break down. But it's a way for me to kind of focus on diseases that affect a lot of people. It also is a way for me to keep some of my internal medicine training, because a lot of times with some specialties, you'll focus on the specialty, you won't focus on the other stuff. But like for us, we have, we focus on the kidneys, but a lot of patients when they lose their kidney function and go on to what we call dialysis, which is personal kidney, we wind up seeing them a lot, and so we have to keep an eye out on a lot of general medicine issues. Even if it's we're working on it, we have to keep our minds sharp about that. And so it was a way to kind of focus on a certain organ, but at the same time kind of focus on kind of take care of a whole person. So those are some of the things that attracted me to the kidneys.
Okay. So how much of a difference do lifestyle choices make for kidney health versus heredity?
Ooh, that's a great question. That is an awesome question right there. So lifestyle choices are huge, really, in chronic diseases in general. Actually, last year I actually did. They actually have a lifestyle medicine training course. You can get certified in lifestyle medicine. I actually got certified in it. And one of the things that drew me to this is that as you work, in different areas, you find a lot of commonality, and that is that the things that cause damage to the organ I focus on, which is the kidney, are derived from other chronic diseases, diabetes, hypertension, and those are driven a lot by people's lifestyles. So when I say lifestyle, so you're talking about the things that you eat, how much you exercise, how much sleep you get, how much stress you're exposed to, and these lifestyle choices are huge in addressing and causing damage, and also preventing future damage. So we talk, so when we hear these words, these buzzwords, lifestyle things, they're really real. I've seen people change, the trajectory of their health life, if you want to call it that, or health outcomes by changing basic lifestyles. Now, of course, the question is, okay, is it all lifestyle, is all hereditary? And I don't think there's truly this sharp division between the two. A lot of times there's overlap. So you could have a genetic disorder that's may promote loss of kidney function, but if you change your lifestyle, number one, that damage to the kidney may not occur as early, and even if it does occur, you can slow down how rapidly your kidney function drops by the lifestyle changes you have. So it's not a either or, it's a 1-2. So that's one of the reasons why, even if you have a genetic disorder that may be affecting your kidneys, we're still going to promote lifestyle changes, eating right, exercising, making sure you're at a good weight, because whatever genes or whatever genes you may have inherited that you can't control. Remember, you can't control your genes. You can control the lifestyle changes,
Mm-hmm.
and those lifestyle changes, will influence. And they don't know if it's a direct cause, or your genes may just make you more susceptible to bad lifestyle choices.
Right. So you did talk a lot about the lifestyle choices you can make, like eating right and exercising. So are there certain contributing factors among those things that lead more to chronic kidney disease, like certain things within the diet?
So I would say that in terms of our diet, there's something called Standard American Diet. We actually have an acronym for it. It's called SAD, SAD, Standard American Diet.
Doesn't
And
make it sound good, does it?
right, exactly. Doesn't sound good at all. And so, what the standard American diet is, this is the high fat food. This is processed food, prepackaged food that a lot of Americans eat. And probably over the last couple of years, we've heard things about seed oils and packaged foods of the nature. And I actually heard from one influencer who kind of phrased it in a manner that I think that makes a little more sense. And that is, our food products are hyper palatable. And when I say hyper palatable, they're designed for us to eat more of it.
Mm-hmm.
So, when you hear these slogans, Pringle, well, I don't know if you can say Pringle or not, but whatever. Once you start, you can't stop. Once you pop, you can't stop.
Yep.
And you wind up eating the full bag of chips, the full bag of, whatever.
It's a
The
thing. Yeah.
foods are literally, it's a thing. It's a thing. And it's designed that way. It's
Mm-hmm.
designed for you to eat the whole thing. And what happens is that, you're eating, they're designing the food for you to eat more of it. The food contains a lot more calories.
Mm-hmm.
I'm not even going to get into the things that are thought to be toxic and things of nature that they're still working on sorting out. But, you're eating a lot more food that you should not be eating. And those things lead to the condition that seems to be driving most of our chronic conditions, which is obesity.
Mm-hmm.
Okay. So obesity is a lot of these lifestyle changes lead to obesity, and obesity does the damage. So, from an eating standpoint, if you take the fiber out, what's the fiber supposed to do? It's supposed to fill you up. It slows glucose absorption. So
Mm-hmm.
there are real things that this natural fiber does. Well, if I process my food, guess what I'm doing? I'm taking the fiber out. Why? Because I don't want you to get full. I don't want you to get full.
you want
And I
to
don't
eat
want
the
that
whole
glucose
thing.
to
Yeah.
slow it down. I
Mm-hmm.
want you to eat the whole thing. So let's take all the fiber out. So, so I think so when we talk about medicine and or public health, so from a medicine standpoint, okay, I see the kidney damage to your kidney.
Mm-hmm.
And I know that, I had looking around, okay, the damage to kidney is coming from the hypertension, diabetes, whatever. But then as I put my public health on, I know that one of the drivers for this is because you're overweight. And why you're overweight, because, the food has been allowed to be designed for you to eat more of it, even though it's devoid of a lot of the good nutrients that food is supposed to have.
Mm-hmm. Do you think, do you advocate for taking multivitamins for most people?
So honestly, most people honestly don't need it. So
Really?
unless you have a specific nutrient deficiency, most people don't actually need the multivitamins and stuff of
Uh-huh.
that nature. If you eat a good healthy diet. So if you're
Mm-hmm.
eating if you're eating plenty of getting your getting your proteins in, you're eating kind of a nice well balanced diet. Most people don't actually need it. You're getting some exercise, getting some sun. You're getting your vitamin
Mm-hmm.
D in, and and these sort of things. Most people don't need it. Most people don't need a multivitamin. And but it's kind of marketing that get this and you get some extra energy. Well, maybe you just need to sleep.
Right.
Maybe you probably just need to sleep. So it's one of these things where as I think as physicians, public health, we have to be conscious about the impact of marketing
Mm-hmm.
on our patients or our populations, because kind of like you said, I mean, like I said, whether it's eating more than you should, or if it's taking supplements
Mm-hmm.
that you may not need. But of course, somebody's going to tell you you need this for your energy, for your for
Mm-hmm.
your vitality. But at the end of the day, maybe you just need to eat more salads, get some rest, and you'll just feel better. So
Mm-hmm.
so it's something to be conscious about.
Yeah, that makes a lot of sense. So kind of switching gears a little bit, how long have you been involved with the Ross County Health District?
So I signed up for the Ross County Hospital, I think it was November of 2019. It was a part-time medical director, and I was like, oh, because I've been out, of course, doing medicine for quite a while, and I had this public health degree, and I really kind of wanted to be able to utilize this, and I had an opportunity. A friend told me about the opportunity that was there at the health department to sign up, and it was like, oh yeah, don't worry about it. It won't be that bad. And fall 2019, November 2019 is when I signed up for the Ross County Health District, and it was quite an interesting experience
Mm-hmm.
because about January at that time there was a some little disease that was coming around like
Yeah, you got there just in time for the fun to begin.
just in time for all the fun.
Mm-hmm.
But yeah, I've been there ever since then. So
Okay.
initially, health commission, it was a health commissioner and medical director combined position. Then it didn't take long throughout this pandemic before they were like, can we separate these roles? And they separated the medical director, the health commissioner, and the medical directorship. And I kept the medical directorship, and we got a full-time health commissioner.
Mm-hmm. So what was it like being a medical director at a health department during COVID in the height of all of that?
Ooh, it was challenging to say the least. I mean, I think that the one good thing was that there were just some absolutely positive, supportive, knowledgeable folks in the health department that could help support me through this entity, because for me it was you know I had a full-time nephrology job. Right,
Mm-hmm.
luckily it was in the same city, so it was okay. But I had to see patients and go to meetings for the health department. We had so a lot of times if I'm missing a meeting, I had to rely upon someone to kind of fill me in, and then we
Mm-hmm.
could discuss about what needs to be done next. But it was still a challenge. There's still the stressors like everybody else, and of course I'm seeing this from two different perspectives. I mean, there's the population piece, and then of course we got the individual things in the hospital that you see. So it was pretty stressful. During that time, just not, and then remember, a lot of times initially, didn't have supplies, didn't know what was going on, didn't know what to
Mm-hmm.
do for people. So you're trying to find um, you know, other health departments, seeing what they're doing, kind of seeing what, because sometimes you'd ask stuff in Columbus, but like I said, Columbus has a different, it was spreading differently through like the major cities than it was in the rural areas.
Mm-hmm.
So, you could talk to them, but like I said, then you also want to talk to somebody else that's, in another rural area to see what their experience was. So it was challenging for, all, well, I guess it's challenging for everybody, but like particularly, for us, because like I said, we're trying to figure out what's happening, what's going on. But like I said, the folks in the health department were great in terms of support, and providing some knowledge. And, we had, of course, we had Michelle then. And like I said, Michelle had been through another, pretty much a pandemic before anyway. So she
Mm-hmm.
could really provide a lot of insight, and a lot of support. So it was a challenge, and we just saw it through. That was saw it through, but it was for a while there.
Yeah,
It was
talk
like
about
late calls,
being
like,
yeah, talk about being baptized by fire when you get in there.
but there you go.
Yeah. Well, it sounds like you got some great experience.
Baptism by COVID-19.
Yeah,
I was like,
exactly.
wait, like, oh wait, right? It's like, look out. Oh, it's like, yeah, you start watching the news, like, oh, it's spread in this country, it's spread in this country. Oh, it's on the West Coast. Like, wait, y'all slow down.
Yeah. Like keep that over there. We don't want that. Uh, um,
Exactly.
so what are some of your duties as the medical director at the health district?
Okay. So, as a medical director of the health district, so I guess a couple of things. So, of course, we have a clinic, and then there are certain duties, certain things that have to be signed by a clinician, that we have to do. So, I would say a lot of it is providing insight,
Mm-hmm.
for various issues that may come along. I think I probably for us, we have a latent TB clinic. So, those individuals have to be evaluated. You have to decide whether or not this is, if they meet the criteria for being treated, and then we have to make sure they're monitored. Also, for our clinic, they can also get vaccines. So you have to look through the protocol, make sure those are appropriate, and sign off on those. Then also, there's, the Narcan, also the EpiPens that go out to the schools. We just have to make sure that, because we have to make sure we have a protocol when we send the stuff out there,
Mm-hmm.
sign off on the medications as needed. So those are, and then like I said, there might be other, really a lot of protocol stuff that may come up that, may need some clinical insight. And so I will provide that as needed. And then anything that needs a signature, we'll provide that as well. So that's kind of a big overview of, the routine stuff. And then, of course,
Mm-hmm.
like I said, but so the COVID stuff, I mean, if it gets, if there's a pandemic or some other disease that's spread out there, then like I said, you get a little bit more involved. Hopefully it's something that can be managed, within. But like I said, we're as a health department, we're connected to the community. So something's running through, say, a nursing home or something of that nature, we may have to provide a little bit more insight, suggestions, connections, in order to address issues that may pop up in those areas. So.
Mm-hmm. So it sounds like it's a lot of not only administrative duties, but also lending your clinical insight to a lot of different situations that arise in the county.
Exactly.
Great. So how does having your private medical practice affect your perspective on public health?
Ooh, lovely. I like that. So I think, yeah, kind of like I was mentioning a little bit before. So when you practice medicine, you're focusing on individuals. So one individual comes in, next individual comes in, and so you're focusing on treating those particular diseases that you diagnose and create a treatment plan for on an individual basis. When you do this enough and you start seeing patterns, that's when you kind of swing into that public health role, or you can understand why the public health is needed a lot more. So for me, even before I did the lifestyle medicine, even before I even heard about lifestyle medicine, I will never forget one of the patients that I saw a patient that was brought to me was referred to me for, very early kidney disease.
Mm-hmm.
And the individual had, kind of recently been diagnosed with high blood pressure, diabetes, early stage kidney disease. And, kind of talking through what's going on with the guy. And then come to find out that he was actually drinking a lot of soda, or pop, pop from Midwest, of course. And to the tune of, some days it would be a case a day. And I had never heard of somebody drinking. I'm like, how do you drink that much? But yeah.
How
But
much did he
apparently he was
have?
drinking like a case. Sometimes some days he would go through a case. Yes, a day.
Oh my.
And at first I'm like, okay, how do you do this? But I mean, I guess, he was, he actually was a very hard worker, but, the place where he worked didn't have a lot of, a lot of times it's just vending machines that you eat from.
Mm-hmm.
And then he was a single guy. So like I said, I guess he didn't cook. So he would just drop by, gas stations, get food out of the gas station, get the drinks out of the gas station. And then that's kind of, that was literally his diet.
Wow.
And so, kind of talk to him about it. And prior to this, you hear about people saying, "Oh, soda's bad for you," but most people don't see you drinking like 2 or 3. Not I like I said, I don't even know how you drink them. But
it's like having an IV hooked up of it, basically.
Right, exactly. Like to this day, I still don't understand how you drink it all. But nonetheless, kind of talk to the guy. Say, hey, why don't you, also, might want to get off some of the drink a little more water, this, that, and the other, and kind of taught them some basics about healthy lifestyle. Kind of drop this stuff out. Try and find some fresh food, Well, he did it. He did it. Which, okay, so two things. Number one, I never heard about this stuff. And then number two, you know, as as a doctor, we tell people all the time to eat better and exercise of nature. Most of them don't listen. But this guy actually did. And I mean, when I say stop, I mean he stopped drinking altogether. He started drinking water. He's he was eating, he was fine. If he wasn't cooking, if he wasn't, cooking, then he would like find healthier places to eat.
Mm-hmm.
And, it within a year, like a lot of his, like, he stopped being he got off the diabetic medications, his blood pressure was better, and the kidney function got better, which I had never actually seen.
Mm-hmm.
I've heard of it, but I never actually seen it. And so once you see this, and like I said, this is is a young guy. I think it was, probably in the, right around 40s, like a little less than 40. But I mean, I'd never actually seen it before. And then you start looking at it more, you start looking more and reading more, and you realize that this is a thing that, especially amongst younger people, this is driving a lot of the chronic diseases. Between the food that we kind of talked about before,
Mm-hmm.
the lack of exercise, because a lot of us, what sitting is the new smoking is what the mantra is now, because we don't think about that. So for me, you know, I'm watching this in the practice because I'm prescribing meds. They're coming in, and what are we're trained to do? Like, I went through 4 years of med school, like 5 years of
Right.
training, so I can write you a medication. But it's like, look out. Meanwhile, what you really need is more education about the importance of lifestyle and ways to think about it in a modern term. Because what's happening is that I hate to use the term boomers. Boomers are older people are criticizing, especially in the medical world. They're criticizing it, but the reality is that if you grew up agrarian, or even if it wasn't agrarian, like I said, even if a city, like I said, your food was healthier,
Mm-hmm.
your opportunities for exercise, like just daily activity, were greater. And so you didn't have the pressures or the influence that the younger generation are having. And some of the stuff, in order to get it changed, is a matter of letting people know that it's happened. So like, hey, you need to get 10,000 steps a day, and putting that messaging out there.
Mm-hmm.
And the same thing with the food. Like, okay, so all right, so from a public health standpoint, we can support, more farmers markets, or maybe even educating young people about growing their own food. Get a couple tomatoes in your backyard, and because that impact is huge, and that impact will impact the actual health of individuals. So that if you're hearing this from, you're hearing it from your doctor, you're hearing it from your health department, or the department is putting that information out there for people to hear, you're basically counteracting the influence of messaging that's coming from, really, I mean, corporate is really where it's coming from. Corporations is where it's coming from. So, and then you can kind of address this issue of what's really a chronic disease. I mean, it really is a chronic disease epidemic. It's slower than, say, a viral epidemic like we saw with COVID, but it's still real. And it's slower, but it's still real, because people are getting, they're getting hip and knee replacements at a younger age. Why? Because they're obese, and like I said, if you don't strengthen the bones whenever you're younger, like I said, that stuff can impact you in your middle age instead of impacting you at an older age. So, like, younger people are getting, they're getting heart attacks at a younger age. There's an increased number of type 2 diabetes in children,
Mm-hmm.
which used to be unheard of. It used to be an adult disease. Now it's a child disease. I mean, I've seen one as young as, I think my youngest one was 12, but I have pediatric friends that say they've seen them at 8.
Wow.
So, and what type 2 diabetes is, from, for the most part, from obesity for most people. So the the clinic can no longer manage all of this stuff in a sustainable way. So as a physician, yes, I'm going, if you come in and you have the diabetes, I need to treat the diabetes now. But at the same time, from a public health perspective, they need resources and information to let them know that the reason for you getting this diabetes is because you're not walking, or maybe maybe it's, and the patient may say, well, the sidewalks aren't safe. Well, okay, well maybe there needs to be some education and we need to bring stakeholders together to make sure that these folks have a safe place to walk. Make sure the parks are designed in a way that people can access them, and then utilize that in order to bring the two together, so we can have like just a healthier population. So that so we can have a healthier population. So I think those things coming together are huge. And like I said, I think you see a lot more of it now, but it's one of those things where we have to be a little more conscious about the two sides. And as a physician, I'm going to keep focusing on my individuals, but from a public health standpoint, I think that the understanding that role in preventing or minimizing the amount of chronic diseases here is important, because honestly, I don't even know if we have enough physicians to manage all of the people that are developing these diseases, and especially amongst the young ones. I mean, so for a young person, it's huge, because if you develop diabetes at 15, you still have that same course. So like I said, so say before the average, I can't remember what the average age was for developing diabetes in the past, but if you develop it at 40, and like I say, now you get your heart attack at 60, well, if somebody gets it at 15, you got to back it up that number of years. So now you're going to get your heart attack at 35, 40, and that's not unheard of. So that's where all this stuff kind of brings itself together. And I'm glad to see more emphasis on lifestyle changes. I think that it will probably come. I think it'll probably become more. It is becoming more part of our clinical practices and incorporate. But at the end of the day, you also have to remember, like as a clinician, like I said, I am trained to treat the disease, and I can tell you about stuff. But like I said, having like I said, most docs only have 10 to 15 minutes to talk to you. So you got to do some other. The support for healthy lifestyle changes has to come from someplace other than just that 10 to 15 minute interview inside of a clinical practice, because it's not enough time to give you all the research. I mean, we can plug in directions and say, hey, this disease could be improved with lifestyle changes, but then there needs to be some follow-up to kind of support that person through that journey, because it is a journey. It's like, if you've been living unhealthily for 30 years, you're 30 years old, you got hypertension, diabetes, you got to untrain, 30 years worth of bad habits. So
unlearning the habits, so to speak. Yeah,
exactly.
Yeah. That's one of the great things about our Creating Healthy Communities program. Jordan George is our CHC coordinator here at the Ross County Health District, and she's got a lot of great partnerships with some of the community organizations like the Ross County Parks and Recreation. They've worked together on getting some accessible trails around the county, and I know she does some work with physicians doing produce prescriptions, and she's done some partnerships with the local farmers market as well. So I know she's doing a lot of great work trying to also promote active transportation. We're a partner with the Chillicothe Ross County Public Library System and some others for the Book-a-Bike program, where with a library card, you can check out a bicycle for free.
Yeah, that's huge. I like that. I actually love that program.
But CHC is a great proponent of active transportation, healthful eating, and we've got a lot of great projects that Jordan's got going here in the county with that. So that goes a lot with what you're talking about with some of the lifestyle changes, and she's got some really exciting things on the horizon that she's been working on with that. So you'd mentioned before with your patient that drank the case of soda a day, you said that you'd heard of people turning their health around with lifestyle medicine, but you've never actually seen it. So did the majority of your patients not take your advice, so to speak, as far as making lifestyle changes?
It's not unheard of. So no, I think if you had 10 docs around, most of them would probably have, I think everyone has success stories, but I would say that most of them, the majority of them, are probably going to say that, hey, yeah, I told them that, and they didn't follow through. They're still eating the stuff that we told them not to. And that's, yeah, I would say the majority of them would probably say that people don't listen to them from a lifestyle um, change perspective. But yet again, I think that it's, a lot of it is very, it's very difficult because, like I
Mm-hmm.
said, by the time you see the doctor for your condition, I mean, I think we're trying to get people in a little earlier now, but especially like as a nephrologist, a lot of times, by the time you see me, you have been to a primary doctor, whatever conditions are going on have been happening, and now your kidneys are failing.
Mm-hmm.
They don't call me preventatively. They call you once that kidney has, either been significantly damaged or has lost a lot of its function. And so, I'm trying to add that on top of that. Now, I think that the one good thing for that is that sometimes what you can see is it's almost like a fear tactic.
Mm-hmm.
Your primary doc, because I've had people, somebody say, hey, the primary doc did something, and I know the docs, but I think that what happens is that, you know, whatever you were told before doesn't become real until you're seeing a heart doctor, a kidney doctor, stroke doctor or whatever. And so at that point in time, oh, now I understand why I need to control my diabetes, why I need to control
Mm-hmm.
my high blood pressure, because I don't want to, I don't want a heart cath. I don't want to be on dialysis. I don't want to be, I don't want to get, whatever that end organ damage um, is, so so that piece I think is very real.
Mm-hmm.
Is that, that sometimes people don't believe it until stuff starts happening.
Yeah.
So, and it's unfortunate, but like, it's most people, most people's doctors are going to tell them to eat healthier. And then the other thing is this, that, for American healthcare, for the most part, you don't get trained, you don't get nutrition trained. I think we got like a few weeks or whatever in when I was training in med school, but most of us don't get actual training
Mm-hmm.
in nutrition and exercise, stuff of nature. So we can say, hey, you need to eat better. We'll print out a paper, but then you got to translate that into knowledge and action, and that doesn't happen in most people's clinic. And most people's clinics are not set up that way. They're just not. It's just not how it's set up. So like, yeah, in my brain, put my physician hat on now. My brain, okay, I see you. I got your diagnoses. Okay, you need to eat right, increase your fiber, the whole 9 yards. Here's some pamphlets. All right, and we'll see you again in 3 months. Then, then that person's taking that stuff out there, and you know, most people are going to read it. I would
Right.
say, think about the number of people that read the papers that they hand to you whenever you check out. I mean, most people, if you take your own self-assessment, have you read all that stuff? And the answer is probably not.
Mm-hmm.
So, so that stuff becomes real. So you come back in 3 months and the same, and what I'm going to do, okay, well, your blood pressure, said, if because the other thing is this, if the medication has worked, then, I might tell you to eat less salt or less sugar. But like I said, if this pill is working and there's some pie over there,
Right.
like, it might it might look a little different. So yes, I think that there's a lot of things that go on in that medical public health space that's that we're starting to give a little bit more attention to
Mm-hmm.
in terms of the complexities of how to get how to get a human to live in a healthier lifestyle and have healthier habits. So, and and you do see some young folks that seem to be kind of leaning that way. Heard actually cool little rap song where they were promoting vegetables, eating vegetables and avoiding chips, which I thought was kind of cute. So
Yeah.
we'll see if that stuff starts to grow a little bit. So.
Yeah. Well, you talked about with the sad American diet about their hyper palatable foods. And when you're
Mhm.
trying to shift lifestyles from eating unhealthful foods to more healthful foods, I think another thing is kind of coming off those addictive properties in those foods, like coming off of sugar, because it is almost like you're addicted to it when you've consumed so much of it, isn't it?
Oh yeah, yes. You're absolutely correct. Sugar is addictive. Just in general, there have been some people compare a sugar addiction to a heroin addiction. It is real. It is very real. Dude, one of the things I tell people when I'm giving, lifestyle change advice, I let them know, like, no, it's not in your head. You may be addicted to sugar, and you will have to break that addiction. And then I have some steps, where I tell them how to kind of step back away from it, and to understand, especially for those individuals that really are really, because some people just they have sugar cravings, and it's break this stuff, and then some people really, I mean, they have a problem, they have some issues, and they have to understand it's almost like like an alcoholic, like once you stop, you can't go back. And some people are that bad. Most people, it's just a matter of once you break it, you find you might need a cookie or something of that nature later on, but you can control it. But a lot of people, I think, yeah, a lot of people, number one, don't understand that stuff is actually physiologically addictive. And then the other thing is understanding that you may be eating more of it than you think. Because like I said, some of the people that are trying to lose weight and quote unquote can't, a lot of times if they really look at it, they're probably snacking, and kind of sneaking stuff and don't really count that. But yeah, that stuff, the sugar, especially like I said, especially the sugar piece is huge. And people have to understand that yes, you may actually be, if you're trying to lose weight or eat better, you may be addicted to sugar, and you may need to talk to a dietitian or something, to really kind of find strategies to break that addiction, especially if you know that it is driving bad health outcomes for you. It is very real. It's very real.
Mm-hmm. So would you say that would be the number one call to action concerning health and wellness that you would urge the public towards, is eating more healthfully?
I would say. So. I think two. So I would say two. So I think your diet is huge, and in lifestyle medicine, we kind of promote a whole food, plant-based diet. Now I say plant enhanced diet because I still eat meat, but
Yeah.
but I think I still eat meat. As far as I'm concerned, my veggie burger is an actual steak, so it's like it's all plant based. But seriously, so the whole food part is you try to get your food as minimally processed as possible. So you want to get it fresh off the vine. And I like farmers markets, so go get it from a farmers market, grow it in your backyard. That sort of food where it's very minimally processed. And if you do, say, hey, I don't have a farmer's market near me, you go to grocery and like try to get the frozen stuff versus the canned, because especially frozen vegetables, a lot of times they're frozen near the places where they're picked, and so it's some of them can be almost as good as getting it out of the field. So a whole food, plant, like I said, plant predominant most, and part of that sad diet is a lot of times we don't eat enough fiber. So you want to enhance the plants that you consume, the fiber, especially the fiber containing plants. So, like green leafy vegetables, beans are huge. Like I said, enhancing that as a part of your meal. And I really like that. I think, and this is one of the things, a lot of these healthy cooks and so in nature, beans are extremely healthy. They're high fiber, they're high protein. They have a lot of other nutrients that are in there. You can get dry beans that you can store on your shelf. So even if you are in an area that doesn't have like a lot of grocery stores or anything in nature, you can go somewhere, get you a whole ton of beans of different varieties, and you can use those. You can cook them. They store well even after cooked. So those are huge. So whole food, plant based, increasing the fiber sort of diet. And now a lot of times they will also, the plant based, from a statistical standpoint, or like you look at the studies, seem to be the better of them. But like I said, if you do eat the meat, of course we promote fish, chicken over beef and pork and things of this nature. I also say, like I said, if you are going to get the meat, try to get that stuff as sustainably sourced as possible. So if you can buy your beef from a local butcher, that usually is a little bit healthier, or thought to be a little bit healthier than the ones that are heavily raised on the food farms or stuff of that nature. From my perspective, I think they taste better.
Really?
It tastes better. So yeah, I tend to go to butchers. I like butchers, especially like local butchers, to try and get my meat. So, but that's just I'm off on a more personal thing. So I think the food part is one, and then the other is activity or exercise.
Hmm.
Yeah, trying to get more activity in. We gravely underestimate, over the last it's like 50 years, how convenient our life has become as Americans. And and the cost of that convenience is that we don't have opportunities to exercise or to do activity, and it's starting to pay out. It's starting to we're paying a health cost because of that. So like I said, whether you're picking stuff up, even the garage, you take fewer steps because you pull your car right into the garage and take fewer steps to get into the house. So like that's different than parking in a driveway or on the side of the street. So
Right.
you're cutting those steps off. Most of our jobs are sedentary, so we're sitting all day. So we're missing those steps out of there. If you, and even if you have those, these jobs where you work at home and basically quote unquote telecommute or whatever, but you're sitting down all day. So you got to make sure you get those extra steps in. That's different than being at home. Even the cubicle, as unhealthy, probably unhealthy as cubicle was, you did have to get up and go to the coffee machine. You had to interact with people. So those two would probably be the biggest two. So what you eat, and make sure being more mindful about your activity and how many steps you get in and how much walking, how much exertion you do.
Hmm.
Don't try to park at the as close to the store. Park at the end and walk. Get those steps in. Get those steps in.
Yeah, they pay dividends after a while, don't they?
They pay dividends. They pay dividends. And also do a walk. I mean, just do a basic, like if you're healthy enough, do a basic walk either by yourself or with your family. It's, if you got a neighborhood, walk around the neighborhood, and, see some neighbors, watch the birds, so all those sort of things. It does pay dividends. They have dividends to it. You feel better. I'm trying to look up some of the stuff where, there's positive psychiatric effects. So like I said, people feel less depressed when they take a walk.
Hmm.
So those sort of things. So I mean, really, it's kind of going back to our grandparents' age. Where you kind of got your dinner out, half of your dinner out in the backyard, and you socialize a little bit and walk a little bit more. So those sort of things I think are going to make a comeback here. So.
Yeah, what do they say about like the mental health stuff? Like go outside and touch grass, like just getting outside and getting fresh air, that it really makes a lot of difference with those things.
Makes a lot of difference.
Yeah.
It makes a lot of difference. Exactly.
Yeah.
Exactly.
Well, Dr. Brown, do you have anything else you'd like to add to our conversation?
No, I think this was great. I really enjoyed this. This is a great conversation that we've had here. I'm glad. Thank you. Like I said again, thank you for setting this up. Thank you for interviewing me, and but I appreciate this. I mean, I think this is great. This is going to be wonderful.
Well, thanks so much for taking the time to talk today. We really appreciate you joining us.
Thanks a lot. Take care.
Visit our website at rosscountyhealth.org for more information about our programs and services, and follow us on social media for updates. Until next time, take care and share the health.